This is Dr. Lori Gardner, and this is a brief lecture on gastroesophageal reflux and peptic ulcer disease. Very brief. The objectives are to describe the pathophysiology of GERD and peptic ulcer disease, discuss the rational drug selection for GERD and peptic ulcer disease, and describe patient education requirements of patients with GERD and PUD, respectively. GERD results from the reflux of chyme from the stomach into the esophagus. The physiologic action of the lower esophageal sphincter, or LES, is critical to maintaining a pressure barrier between the stomach and the esophagus. In patients with GERD, the resting tone of the LES tends to be less than normal, permitting transient relaxation of the LES 1 to 2 hours after eating. This relaxation allows gastric contents to regurgitate into the esophagus. Medications can increase or decrease LES tone. Drugs that increase LES tone include bethanochol, metoclopramide, phenobarbital, histamine, and antacids. Some of these are used to treat GERD. Anticholinergics, theophylline, caffeine, demerol, and calcium channel blockers, those are some of the medications that decrease LES tone. And I am going to use LES throughout this lecture. Remember, that is the lower esophageal sphincter. Let's talk about the pharmacodynamics. For GERD, drugs to reduce the amount of acid, histamine H2 receptor antagonists, proton pump inhibitors. Drugs that improve peristalsis include prokinetics, and drugs that decrease mucosal exposure are drugs that are cytoprotective agents, which I have discussed in another lecture. Drug therapy for dyspepsia or mild GERD, antacids and lifestyle modification, H2 receptor agonists. If they have moderate to severe GERD, use proton pump inhibitors for 4 to 8 weeks. If the symptoms are unrelieved, you can increase the PPI to twice daily. You can use a more potent PPI or an extended release formula. Maintenance PPI if symptoms recur after weaning off or for erosive esophagitis or Barrett's esophagus. If the symptoms persist, refer that patient to a gastroenterologist. So let's talk about pediatric GERD. GERD is very common in infants. It's normal in 50% of infants and occurs several times a day in healthy infants, peaking at about 4 months old. Most of these children will outgrow GERD by 12 to 18 months. And no evidence supports empirically treated GERD in infants, so we are not empirically treating babies, right? Refer them to a pediatric gastroenterologist is suggested if symptoms worsen or do not resolve by 12 to 18 months. Most of you will probably refer much sooner. Aggressive management is reserved for poor weight gain, feeding refusal, arcing and crying during feeding, arching. So if that baby is very uncommon, persistent irritability, pain, apnea, and cyanosis. If you're in family practice, you want to refer this infant out. In older children, symptoms that suggest reflux include lower chest pain, dysphagia, hematemesis, iron deficiency anemia, wheezing, aspiration or recurrent pneumonia, chronic cough, or stridor. Consultation with a pediatric gastroenterologist specialist is needed for infants with suspected GERD because of the difficulty in accurately diagnosing them. PPIs are first-line treatment of reflux-associated erosive esophagitis. Omeprazole is approved for children. Omeprazole, esomeprazole, lisinoprozole, and rabdaprozole. H2RAs are second-line treatment. A trial of 4 to 8 weeks in older children or adolescents is okay. Refer to a gastroenterologist if no response. Remember, there is association of gastric cancer with long-term use of PPIs. PPIs for longer than 2 years increase the risk of hip fractures in high-risk patients. You want to monitor for symptom relief, healing of lesions, prevent complications and relapse, and also discuss lifestyle modifications, and some drug therapies are lifelong. These you will not use continuously. Remember, refer these patients out. Patient education, you want to tell them to avoid alcohol, tobacco, the use of peppermint, chocolate, and foods with high fat or high carb content. Losing weight, of course, is also a good choice. They need to adhere to the treatment regimen. Educate them about the reason for doses and the schedule of drugs, and of course, potential side effects, and coping mechanism for complex drug regimens. Weight loss may improve symptoms. They need to sleep with the head of the bed elevated 6 to 8 inches with bed blocks or wedges. Avoid the recumbent position within 3 hours after eating. Avoid bending over within 3 hours after eating. Avoid exercise, especially strenuous exercise, within 3 hours after eating. They want to attain and maintain appropriate body weight, and of course, discuss dietary considerations. Tell them to eat moderate amounts of food at each meal and not to gorge themselves. Also, avoid eating meals or bedtime snacks within 3 hours of going to bed. Peptic ulcer disease, we will talk about that because it's a common clinical problem, and estimated to have a lifetime incidence of 1 to 6% in the general population. The rate of hospital admission for uncomplicated ulcers has decreased significantly, making this largely a disease that's treated in the primary care setting. Helicobacter or H. pylori infection and the use of NSAIDs and aspirin are the common causes of peptic ulcer disease. Additional risk factors include smoking and alcohol use. Reduction of stress and other factors that increase gastric acid are still included in the disease management. Peptic ulcers fall in 2 categories, either duodenal ulcers and gastric ulcers, and each has slightly different pathology and treatment. Peptic ulcer disease is a chronic inflammatory condition of the stomach and duodenum. It's a result of increased acid and pepsid secretion, impaired mucosal cytoprotection. Use of NSAIDs, H. pylori is also a big culprit. So next we're going to go over a quick chart. So step 1, lifestyle modifications and acids. That's what you're going to go to first. Next, test for H. pylori and use a proton pump inhibitor. If it's uncomplicated, You may have to treat H. pylori with antibiotics and a PPI, and we'll go over some of those treatments. Continue that PPI for 8 to 12 weeks until healing is complete. If they're low risk, there's no ongoing therapy. High risk, consider chronic suppressive therapy with a PPI. You're going to refer this patient out. Complicated therapy includes bleeding, so you're going to refer them out. They will have treatment for H. pylori, but refer this patient out. For peptic ulcer disease, all regimens include a PPI plus antibiotics to treat H. pylori. Eradication of H. pylori is critical to peptic ulcer disease treatment. So all recommended therapy includes a PPI and antimicrobial therapy. Most common, you'll see triple therapy, which is a proton pump inhibitor plus clarithromycin, metronidazole, amoxicillin, and you're going to treat them for 10 to 14 days. Triple therapy, remember, it's an antibiotic, it's flagyl, and it is amoxicillin, so there's 2, plus a PPI. Treatment is 10 to 14 days. Levofloxacin-based triple therapy, if you're utilizing that one, the PPI is twice daily. Levofloxacin is 250 to 500 milligrams twice daily, a gram of amoxicillin twice daily, and they will be treated for 10 to 14 days. Quadruple therapy is a PPI plus metronidazole, tetracycline, bismuth, and that treatment is for 14 days. That is usually used as second-line therapy in patients who fail first-line therapy or if they're allergic to penicillin. Load therapy, that is a PPI twice daily, levofloxacin, niacinamide oxide, doxycycline. Treatment is for 10 to 14 days. Consider adding probiotics like lactobacillus or bifidobacterium as an adjunct therapy. The goal of treatment is to eradicate H. pylori, heal ulcers, manage or prevent GI bleeding, prevent relapse. You want to reduce or eliminate symptoms. Step 1, test for H. pylori. After treating H. pylori, continue the PPI for 8 to 12 weeks to promote healing. Low-risk patients require no further treatment. High-risk patients consider chronic acid suppression therapy. If symptoms are unresolved, refer to a gastroenterologist. You want to educate the patient on tobacco cessation, avoiding foods that cause symptoms, minimize aspirin and NSAIDs, adhere to the treatment regimen that you prescribe, go over the drug dose and schedules, and monitor for adverse drug reactions. Like I said, that was a very quick lecture on GERD and peptic ulcer disease.